Our next guest for the morning is Dr. VIJAY PD, a well-networked healthcare management consultant with experience in projects commissioning, operation scaling, resource optimization and consolidation, quality and accreditation, key resources onboarding, design thinking, lean applications, HIS, LIS, RIS, PACS and EMR implementation, integrated building management systems, facility management, unit retrofitting and patient centricity. He's working as a partner and senior consultant at Integra Ventures, handling more than 15 turnkey design development projects presently, consultancy and advisory services for the 400-bed hospital project, and supports the group expansion project at MGM Healthcare Chennai. He's also the advisor and consultant with Wipro COVID Hospital. A very, very warm welcome to Dr. VIJAY PD.
I'm lucky that today I've got a very interesting topic to discuss where most of us can correlate what's happening with the thing, because upgradation of existing hospitals is part and parcel of any healthcare facility. It may be new, old or the kind of stuff. It may be a brownfield or it may be a greenfield kind of stuff. But there are a lot of challenges upgrading the hospital. So before I start, I think I just want to say one small experience of mine. Like when my grandfather built his house, he used to tell, I planned this house, this is a kitchen, this is a living room, this is a restroom. But when the next generation, when my dad planned, he said, I have hired a civil engineer who planned my house. But today when I did a flat or apartment, I hired a specialized interior architect who specialized in house, who would help me to do the project. So for the last 3 generations, the transition of using qualified technical people is being part of everything. I've just taken an example of small house itself. So that's where things start. So coming to my topic today, it's upgrading your hospital. What are the challenges we are facing in it and commissioning issues in it. So just to understand, I think most of you would be part of an organization which has started more than 20-25 years back, at least 50% of the thing, which would require change to go ahead to sustain the competition. So we will discuss today's topic in 3 aspects. What is need? Why is the need for upgradation? Then after for doing upgradation, what is the outcome which we are expecting? And mostly the common problems which are encountered during upgrading. So this is a very interesting slide which I am using for the last 10-12 years in most of my presentation. So there are 3 aspects for any hospital or any building. One is you need an efficient building. Second thing is you need an efficient system. You need an efficient people. People, I mean it is all the HR and all those stuff to run anything. So at any given point of time, there is a lot of flexibility which you have to upgrade your systems without harming much on your operations of the hospital or thing. And also to change people or train people and upskill people so that the systems or the service delivery becomes excellent. But efficient building, it can't be done very often. It has to be planned. So whatever you plan as of today or whatever you upgrade as of today has to cater to next decade of your requirement. So that would be the key principle for upgrading any of your hospitals. So coming to the need for upgradation is the competition basically. You have a lot of new brands or new hospitals which are aesthetically well designed or very efficient hospital systems which are coming into competition into your neighborhood. Then the existing hospitals need to be replanned keeping in mind the efficiency, what it can be brought into the existing hospital, cost reduction. Basically, we are talking about your operational cost and stuff, and maximizing your profit. So, any upgradation has to have this as a crisp of the thing when we are designing. Then, to achieve higher standard of your excellence through accreditation. So mostly you might be upgrading to NABH, or in few cases it may be a JCI accreditation, or it may be anything, even a small NABL accreditation or those kind of stuff. Then to achieve maximum customer delight, most of the hospitals, if you are already 20-25 years old, you would have 2 or 3 generations of people or the family coming to you as a family consultant or family hospitals and stuff. So it's always a challenge to retain the new generation in the same hospital unless you upgrade and compete along with all the competition. So adapting and flexibility towards growth and change of technology. So today, if you see any modernly built hospital, the kind of technology which they use, the kind of comfort they provide to the patient, maybe from a simple registration or online registration or a kiosk to ordering food directly through an app from your room, or kind of information which you would get, like once you have registered your status of your bill, your reports which you get as your SMS or WhatsApp or all those kind of stuff. Then hitting a glass ceiling. So basically this is a problem in most small hospitals where you have limited capacity of hospital beds. It may be 50 beds or 80 beds or 100 beds. Today, any big consultant who wants to come and practice with you expects that he would have a flexibility of using 15-20 beds in his own name or kind of thing. Because always they see for growth, or they see for hospital beds availability as a priority for them to practice. So today, if you see, the complete clinical practice is also shifting from an individual or visiting consultancy practice to a centralized practice where most of the doctors are trying to hook to a single brand or a hospital, build practices and build teams there. So usually here, how do you create your excess capacity so that it is allowed to get more consultants or more teams or more departments into your hospital? Then new specialties to be addressed. The old hospitals would have limited flexibility and stuff, so how do you bring in new specialties with the upgradation? To create efficient building leading to optimal utilization of resources. Resources mainly here, I mean water, your electricity, your space, all those stuff into. So again, like we discussed, the drivers of growth is basically demographics. Again, here why I put this word demographics is mostly even if the hospital was planned 20-25 years, it may be on the outskirts of the city that time, or it was a hospital which was serving a minimal population. But today, that hospital would have been a center for the city or the suburb there, and the hospital can cater to a higher population. If initially 20 years back it was planned for catering the primary population of 50,000 people, today the same primary market has grown to 5 lakhs or 10 lakhs kind of stuff. So how do you address it or cater to it? Rise of affluent population. So this is again a major challenge which most of the hospital has to address. Today, paying capacity for healthcare requirements have drastically increased, either through insurance which they are doing, or through the corporates which they are working, or elderly people getting covered with insurance through kids working in corporate and stuff. So the paying capacity of your patients have really changed compared to 20% or 15% of your insurance cases 10-15 years back to almost a few hospitals where it's reaching till 70%. That's the thing. Then demand outstripping the capacity. Yeah, basically most small hospitals or the old hospitals have the problem with addressing the capacity of utilization. Then aging facility. So now once we plan to upgrade a hospital, so basically we try to bring in all those things into a new hospital or a new upgradation. That is, we would like to drive efficiency into it, then compliance to the norms of the standards, then improve revenue streams. When we upgrade, obviously we expect a ROI on the thing. Then clinical excellence in terms of overall service delivery and better cost efficiency per square feet. Okay, so let's address now, once we take an existing hospital, what are the common problems encountered in an existing hospital. One, maybe in few places or may not be in few places, inefficiency is the major one which we would come across. Then the second thing is minimal accessibility. So maybe minimal entrances. Today if you see any well-designed hospital, you have a separate patient entrance, you try to give a separate emergency entrance, your staff entrance is carved out separately, your service movement is carved out separately. So it may not be possible with an existing hospital, but we try to segregate the traffic as much as possible when we are replanning it. Then there was a lot of uncontrolled circulation in any of the old hospitals because it grew from 10 beds or 15 beds to 50, 100, 150. So you would have faced even a problem like having different heights and different blocks, connecting between the blocks, and the age of different blocks is different. How do you manage all those things? Then the other thing is your poor aesthetic appeal. I think I have slides for this. Yeah, you can just lack of security and safety in few of the things. Control of people coming in, going out. Then poor therapeutic environment. Poor, I mean basically it is not efficient to zone as per the requirement of NABH and ASHRAE and all those stuff, so how to upgrade. And lack of expandability. So you may have or may not have flexibility there in the thing. So coming to inefficiency, again, here if you see most of our old hospital practices, we had very minimal OPDs. A 100-bed OPD, that 100-bed hospital that time, the planning standards, they used to have 8 to 10 OPDs. But today's practice is shifting because of the subspecialties and because of the departments or team. The requirement is almost doubled. It's like closely 20-25 OPDs. So most possibly in an existing hospital, you have converted every small possible room into a OPD or a consultation, or you have eaten into the outpatient waiting area. So there is a lot of crowding which is happening in the outpatient area. Peak hour movements are always a challenge because there is cross movement or the entries through one, or you still have the centralized registration or centralized cash collection kind of stuff where everything is not yet decentralized, maybe because of space and stuff. Then we discussed on multiple crisscross. So in old hospitals again, we find a lot of challenges on vertical and horizontal. If it is a very old trust hospital or a kind of missionary hospital, you had G+1 kind of stuff where you had to travel a lot inside the building to reach different departments. So again, in most hospitals, when we surveyed, we come across efficiency of wheeling in a patient on a stretcher or time in front of waiting area, in front of OPDs and stuff to reach either the diagnostics or OT or thing. So there is a lot of crisscross between your IP services, OP services, emergency services, all of those things. Then centralized or main reception building, which we discussed, and lack of vertical movement. So initially, most hospitals would have planned for a small ramp to take the patient up, or even your lift course may not be supporting you because those hospitals were never planned for a bed lift. It would have been for a small passenger or a wheelchair lift, or to max a stretcher lift which was planned at that time. So the other problem which we encounter is restriction in terms of flexibility and expandability. Again, this is because of the unplanned organic growth which has happened. So over in time, when hospital keeps expanding, demand comes, so you keep adding floors, or you keep adding buildings, or in most of the hospitals I've seen, it's been the next sites or next buildings are acquired, connected and expanded. So which is building in a lot of inefficiency when you take the overall operation of the hospital. So no room for expansion, either departments or services. That's the major challenge again we find, because the requirement, when you sit with a promoter and list down the list of requirement, always your requirement is more than the space which is available. Then departments in bits and pieces, mostly you have OPD one side. I'm just saying, like, if you take a gastro department, you have OPD one side, you have your endoscopy somewhere, you have planned your ERCP somewhere. So this is causing inefficiency even in the clinical team to run around everywhere. In most old hospitals, your CSSD is different. It is not part of your OT complex, or it is in different flow. So how do we make it again efficient? Then unplanned commissioning and expansion. So because of the pressure of those demands in between, when the hospital was in growth phase, a lot of unplanned expansions and commissionings have happened. So how do we undo it? Then the third thing is we come across poor therapeutical environment. Basically, most of your OT complexes, where we have a lot of challenge to make it NABH compliant. Basically, you have to put a basic your AHUs, your ducting and all those stuff, because you have a challenge in height, you have challenge in positioning your AHUs, you have challenge in ducting and all those stuff. Inadequate planning in critical areas, because most of these hospitals, to be frank, were not planned to manage more of critical services that time. A 100-bed hospital usually that time had roughly 8 or maximum of 15 bed of ICUs. Today, most hospitals tend to plan 30% of their beds as your ICU beds. So how can we upgrade that capacity? So again, most of the previous ICUs, if you see, it is all run on a split AC or a maximum ductable AC which is there. But how do you again make it therapeutical environment? You can bring in that required ASHRAE standards into your HVAC requirement. So these are the things which we need to take into the upgradation. Then high rate of hospital-acquired infections due to poor planning, maybe because the locations which you have planned, because of the old lines which is happening, mixing of air, there is no compartmentalization between sterile zone and unsterile zone. You have not planned the system accordingly. Then haphazard inpatient flow. Sometimes you are shifted from OT directly to a different flow. You don't have pre-op or post-op exactly available there. It's been in few places I've seen pre-op and post-op where patients are shifted to completely a different block, not in the block of OT which you do. There is a limited access between emergency and to your OT or ICU. So a lot of haphazard inpatient movements are happening. Then circulation constraints, again, most of it is repetition. One is entrance. So starting from entry of patients, segregating your ambulance movement, segregating your service movement. If we don't have flexibility of having so many entrances, how do we segregate time or kind of stuff? How do we create different entrances? So a well understood healthcare planner or an architect would add value into this. Then circulation we discussed. Vertical circulation, yeah. In most of the hospitals, we find a challenge putting in core for a vertical circulation. You would still efficiently do outpatient department or your OP lifts, but always a challenge to put in an IP lift because of the size which it would require. Then user-friendly. Few of the hospitals which were planned initially were not disabled-friendly hospitals. Sometimes you don't see even ramp kind of stuff. Even today, if you go to a smaller towns, not in bigger towns at least now, where there are no lifts between ground floor or first floor, they either use ramp, and even some places I've seen 4 people still carrying patient from one floor to other floor. So that's the kind of inefficiency old hospitals and buildings have. And not to mention poor aesthetic appeal. It's not because it was done badly, it would have been done very elegant to the time that time, but that has not been upgraded. If you take a thumb rule of any hospitality services or stuff, they usually upgrade their interiors every 6 to 7 years kind of stuff. But hospitals, even after 10 years or 15 years, most of the time, the interiors of the stuff have not been upgraded. So that's, you could still have those look of old marbles available. If you see OTs, you have full walls which is cladded with marbles or tiles. You have still, at least most of the places, they have moved away from split AC or a window AC to at least a split or a ductable AC, but still not to the thing and stuff. Then what problem does this cause? Always when you go into a very efficiently planned hospital or stuff, when you step, today you can do a brand recall just by seeing the interior of a hospital. When you are there, you can correlate it. This is a color which is used mostly in Apollo Hospital, this is a color which is used mostly in Therapeutic Hospital. So the branding of the thing, the brand recall, the interiors. So today everything goes hand in hand. So initially it was not so. So today your logo matches your interiors or the language or the theme which you like to have. Then challenges to upgrade interiors again. So mostly you find challenges with the height, your width of the corridors, your door entrances. Sometimes the grid doesn't allow you to expand as per your requirement. So these are the challenges which you usually find. So let me quickly try and give you few basic things which we come across. I will discuss in 3 buckets. One is MEP, your structural and other things which we usually face in a hospital when we upgrade. So basically, grid size in a hospital is a very important factor, either to put in a OT or a ICU or to a room and stuff. So today, if you are planning for a hospital, a decent size OT, which is 300 or 350, I'm not saying 500 square feet OT, 350 square feet OT also, if you don't have a proper grid size supporting you, you end up having a pillar or something popping out within your OT. Or it's a similar case in your ICU and stuff. So we face in most of the hospitals the grid size in upgradation, which becomes a challenge for us to plan things efficiently. Second thing is height. Mostly these hospitals which were planned were not planned for a centralized AC or a false ceiling kind of stuff. So we try to retrofit most of it, try to put a false ceiling, try to do the thing. If it happens unplanned, then you end up having a very low height hospital once you finish. So you don't get that comfort of what you need kind of stuff. Because today, anything in a hospital, if you have to run all the services below your existing ceiling, somewhere 300 to 450 mm, that is 1 to 1.5 feet is what we require below your below your beam. So that becomes a challenge when we are planning, replanning to improvise the stuff. The other thing we discussed was lift core. Then the next challenge is always additional floors. Most of the time they push us to add an additional floor, but few hospitals have really planned well where there is a load bearing capacity available for adding another 1 or 2 floors. Few places it is not there. Few hospitals we try to retrofit or give additional supports or try to extend and support the thing. So adding additional floors always is a challenge, but most of the places where we have option of adding additional floors have really helped, especially planning our critical cares, taking there, so which solves most of our problems. Then the other major thing which we encounter is different floor levels. Basically, if the hospital has grown over different time period, if there are multiple blocks, there is always an issue with the floor levels. Then the foundation for additional floors which we discuss. So here always our advice would be, please get it rectified or check from your structural consultant. Please do take adequate professional help when you are loading or adding kind of stuff. See, most of the hospitals come up and say, we have the terrace which is not used, can we put a light roof there, use it for most of the things and stuff. So, but before going into that, please get a professional help, get it assessed and then plan for it. So, coming to MEP challenges, let's discuss it services wise. Let's start with the PHE thing, although it's down. Mostly toilets and your PHE lines and your STPs and stuff would be a major revamp which would happen in any renovation of the hospital. So, in olden days, hospitals were, toilets were never planned towards the corridor side, or I mean the inner side. Mostly your toilets were placed outside, towards the outside facade area where you could draw a shaft or lines and then drain the things out. But today, with the aesthetics or the look and feel and stuff, mostly we try to bring in most of the sunlight and stuff. So we try to create a whole window. We try to convince promoters to reshift their toilet code wherever it is possible, so that we can address the aesthetic of the room. The second major challenge which we come across in toilets is, most of the previous hospitals you had a raised floor. The toilets were at the not same level as your room floor. There is a small step which you climb. So, which you would also have experienced so much of trip of patients falling in or complaining, or wheelchair can't be taken into the thing. So, whenever you renovate, you try your maximum to please bring the floor level same, so that your toilet and your room floors are in the same level. Then the other thing is the sunken slab. Sometimes that's a major issue. We most of the time don't find where we get leaks. Sometimes it's addressed, sometimes it's not addressable. So waterproofing of all your floors or wet areas when you redo a hospital is very key. Please do not dilute on that, even though it requires a bit of investment, because once you do all your interiors and you start finding waterproofing issues and stuff, you cannot really address it. It's a way to readdress it. Then, most of the places we find issues with the hot water circulation. Today, you plan for reuse of most of your water using STPs. Even for your environmental or pollution control board clearances, they ask you to reuse most of the thing. So having separate lines for your flush tanks and stuff, your return line for your hot water will save a lot of water. Otherwise, every time you end up throwing 3 buckets, 4 buckets of water before you get hot water. So all these are golden opportunities to change, and also installing the WTP. Because most of previous hospitals used to use raw water directly. So today, even for your health of your pumps and your CP fitting, treated water is required. So including that in your planning would be very key. So that's the thing, and hot water is. So core cuts and rerouting of all your things, and especially planning your requirement for STP and ETP. Most of the old hospitals never had segregation of your drainage lines for STP and ETP. So this has to be segregated as per the norms. Your OT theatre, your labor rooms, your labs, your dialysis area, wherever you have body fluid or blood being thrown into the sink or drainage line, this has to be drain separately and a ETP has to be created. So this is the time when you upgrade all those things in this stuff. And yeah, so that's coming to PhD. Then when it comes to HVAC, that is basically your air handling, your systems and ventilation system. Most of the hospitals previously may or may not have provision for ventilation, especially for the toilets, inside facing. You would have put a fan and you would have put a toilet ventilator outside the building. So when you are replanning a hospital, ventilation of toilets is very key. So please do stress on providing the exhaust for most of the toilets which do not have direct window outside. So that's a key kind of stuff. Second thing, you have challenges where today for competition's sake you have to upgrade your hospital to a centralized AC. So you would end up having ACs in most of the place, at least for your OPD areas or your waiting areas. Then today by default you have to have a air conditioning thing for your OTs and ICUs, and also so this your consultant would really help work out which is a very efficient system which would fit your hospital. So always a split AC or a kind of is not a solution. So this please analyze the operational cost when you invest into it. Please don't look only into your initial capital cost, because an efficient system which will save a lot of power and energy for you in the long run gives you a better ROI than just going for a split AC or kind of stuff. Then coming to OT and ICU, addressing the challenges. So we would basically face challenges in placing AHUs. If we have OT floor or ICU floor which is sandwiched between first floor and the top floors kind of stuff. In most of the previous hospital designs, mostly your OTs or ICUs were in maximum first floor or second floor, and mostly service floors were not planned. So this would become a challenge. So this has to be addressed on a priority basis. Again, coming to your electrical requirement, the next major challenge when you are upgrading your hospital is your electrical requirement. Most of the hospitals which you would be running would be on a LT connection, not a HT connection. Today, once you put centralized AC, upgrade your OTs, upgrade your equipment, you bring in CTs, MRI, so you would be forced to go to a HT connection. Most of the hospitals where few of the places I have encountered is they have pushed us or pushed the consultant not to plan for a HT, but when they execute and the power requirement goes up, your LT is not really supporting. And you have not planned enough space for your HT to put a transformer, to put your HT panel. So a lot of issues with your electric board to get the thing, overuse or over demand. So when you draw more power than what it is sanctioned, you end up paying your fines and stuff. So all these things which has to be worked out and upgraded in your thing. And next thing is, please check your life or the functionality of all your electrical systems which you are using, starting from your panel to your floor DB, even to the electrical copper wire line which is drawn from your DB to the switch point or a root point. Because after 20-25 years, it may not have the same efficiency or kind of stuff. So once you are replanning, I always suggest my client to upgrade unless it is recently renovated or stuff when you are doing this. So this again has to be done. And most of the hospitals, previous hospitals, the conduits were laid inside the ceiling or the thing. But today mostly we do an open system, putting your cable trays and stuff. So there's always, this challenge can be easily addressed. So those upgradation of all your high side and low side of electrical thing has to be thoroughly taken care. Then coming to UPS plan, which again most of the upgradation things people take it discounted, that okay, we can run it without a centralized UPS or kind of stuff. So please get a centralized UPS planned again. It may be for your emergency lighting, or it may be for your computers, it may be for all your medical equipments and stuff. Give required space for UPS, centralized UPS, and the lining which has to be done. So this makes your life easy. And the most important other thing is the DG, your diesel generator. So you have to really work out on how well those things are supporting you, whether they are fuel efficient DGs which you have. Is it supporting your peak load in all the time? So you need not have bigger configuration DG always. A combination of a smaller size and a bigger size usually works very well for a hospital, because you don't have a same power load requirement at least 50% of your hospital time from evening to the morning. So having a well-sized DG saves a lot of your fuel and power when you are doing it. Then, the major other thing would be addressing your firefighting requirement. Most of the hospitals today in Chennai or any other metros would have already got an advisory from fire department for time to time that these are the things to be addressed, this has to be added, to come to the compliance. So this is a golden opportunity when we are revamping. Please do stress on having the firefighting system which is as per the NBC norms, your local norms. So whatever best accreditation you can have. Basically you have two kind of things. One is your fire detection system, which is very easily layable, because those are all your detectors and all those stuff, which is a kind of your IT system with a PA system and stuff. But the other challenge is how do you put your fire downcomer system. Today, anything which is G+1 or G+2 for a hospital, we subscribe to have sprinkler system in all your areas. So this has to be planned, your ring main system and sprinkler system. And to support this, you need that kind of water sumps capacity. So that also has to be addressed, both underground and overhead tanks. So this challenges has to be addressed when you are upgrading your hospital. Then coming to your light voltage system. Today most hospitals are completely networked. It may be your telephone, it may be your Wi-Fi, or it may be your computer or LAN system, it may be your nurse calling system, it may be your PA system, public announcement, or your code blue system. Today most of the hospitals are also using BMS, building management system, integrated into it. So make sure, even though you don't invest, you have flexibility to upgrade your hospital into a good technology-oriented hospital. Please do provide required spaces for your IT lines. Basically, you need to provide rooms for your shaft and your IT small rooms in each floor, which will help you to address all these things. The biggest thing again, upgrading it into your EPBX system, which will help you connecting all the rooms and stuff. So that has to be taken care of. So these are the major MEP challenges which is on a top line, which has to be looked and addressed properly. Then coming to the construction. Coming to the construction again, when it is a running hospital, you have major challenge is you can't stop the operations of the hospital completely. So in these scenarios, how do you plan your upgradation of the hospital? Second thing, you have challenges in working time. You can't do the project work all the time like any other just regular hospital project. So you have to really plan your requirements and your changes accordingly. And most of the hospitals have minimal space for construction activities. You don't have enough space available to dump your materials and do and stuff. So planning the sequence of renovation is also very important. One simple example, you can't renovate a top floor, you can't renovate a bottom floor and come to a top floor. Because always you find chances of water seepage and stuff. leakages or banding and stuff. Always the principle of addressing it from top to bottom is very easy because you can keep addressing most of the wet areas and all those stuff. So once you do everything, once you put a false ceiling and stuff, you find leakages in the above floor and stuff, addressing that would be an easy, would not be a easy thing. So here again, when you're planning, most of the time when we have space available, I insist the promoters to allot a new place for OT and ICU because that's where major key services, height related issues and all those stuff come. So if there is possibly a new area available, we try to plan that separately so that the existing OT ICU can run easily and it can be migrated. So here again, challenges is please do not compromise on hiring some spaces outside the hospital for temporarily, shifting your non-key activities like your administration or your lab or even sometimes your OPD activities and stuff, which will create enough room for any hospital planner to really do up the hospital. See, again, we also have to understand that there is a time and money challenge. You can't keep running hospital renovation project years together, 2 to 3 years, because every time there is so much sound, dusty environment and stuff, patients keep complaining or there's a lot of issues. So try to minimize your project time. You try to do as early as possible and try to go for a package thing, a single vendor kind of approach who can coordinate things and execute fast. Again, sometimes in few of my projects, in spite of existing promoters insist that they segregate everything, handle things separately. So in an existing running hospital, catching every vendor to come on time and coordinate and running is not easy. So these are the challenges which we usually face when we are trying to commission or upgrade the thing. So at the end of the day, once we do all this exercise, we would like to have evidence-based design which is created for the hospital. Then we would have achieved good operational efficiency from all angles. Then it should be more adaptable and flexible. This is again using the kind of walls or the kind of infrastructure which can be upgraded or expanded easily. Today, apart from wet areas, most hospitals you can construct with dry walls, which is easily convertible or changeable as per your requirement in the future. Adding all the required technology into the system, not just sufficing to the present day, but keeping in mind future next 10 years or 15 years of requirement. Then again, the major thing is cost effectiveness. Please do keep a tab on what you are going to spend on your upgradation and stuff. Every time, every rupee you put, you need to have an ROI. So just because you need to compete with somebody or just to make a hospital look like somebody else's hospital, spending too much without a proper business plan is not advisable. And also make sure you keep your hospital climate change proof. Basically, when the Chennai scenario, the kind of floods it has faced, and the kind of services issues and stuff. So all those climate changes, basically, how do we address your temperature issues? The Chennai is not the same what it was 15 or 20 years back to the present temperature wise. So all those things we have to, and also keeping all the stakeholders happy, medical fraternity, your existing employees, your investors, your bankers, and your promoters. So your design and upgradation should suit everybody. Then the last thing is emergency preparedness, which we discussed. So that's what I had for today. Any questions I will be happy to take if I have.